I'll start with Vikram. Vikram, you've been a healthineer, if I can use that term, for a long time. With an engineering background in the healthcare sector. I know you would say that, which is why I use the term. But I think the word technology, the way we use today, was probably not used the same way many years ago. And health tech, the definition itself has evolved. I want to hear from you what that transition has been, given sort of your history there, and this premise that technology can lead to affordable healthcare. It's a good mantra. It's a good cheer on a Saturday morning. But could you talk about examples where the promise may have been fulfilled, but also not fulfilled? What are the cautions? I'll start with that cautionary tale.
Hear me at the back? Yeah, perfect. So, thank you, Professor Sarang, for the question. I think it's an interesting start because we started our journey about maybe 15 years ago, looking at how technology could actually make healthcare more accessible. And just like any large company that has the wherewithal to go after large problems, we made the strategic mistake of assuming that what we thought was right, which was make the right technology at the right cost and everything else will follow. It did work. It worked for a long time. It continues to work. But what we also understood over a period of time is the amount of impact that it can have is limited by the amount of ecosystem that follows that technology. So adoption barriers are extremely high as far as healthcare ecosystems are concerned. We also learned that technology is an extremely small part of the overall challenge that we're trying to address. Just by way of statistics, if you look at any healthcare system, whether it's in the US, whether it's in India, globally, on an average, most healthcare systems spend not more than 20% on technology. Everything else, maybe land, building, rentals, litigation, processes, insurance, all that takes a large amount of money as well. So, assuming that a small dent on the cost of technology is going to drive healthcare adoption up and therefore make healthcare accessible is a very gross mistake to make as an assumption. So for us, coming back to your question about what does health tech mean, what does med tech mean, and how has that evolution changed? For us today, when we think about health tech, we don't think about that one device that we're building. We start with the definition of the system, and I'd like to go back to what Mr. Kumar was talking about early today, which was think first about the systems and then think about the ways to get the system working. That's exactly how we start today. So when we say health tech, it's always the ecosystem of healthcare, which means 20 different stakeholders to deal with, starting with the patient in the center, got the providers, government, academia, financial institutions, insurance, and the list is very long. So the question is, which problem do you want to solve? What is the ecosystem surrounding that problem? How can tech actually stitch a fabric connecting that entire ecosystem together? I think that is the new definition of health tech. And I think every person has a role to play. If GE comes in saying, here is my technology, here is my device, here's the problem that I can solve, but it is also something that can connect 4 people in the ecosystem, well, so be it. But I think it's important to have that definition in place so that you know what you're going to get out of that innovation, you know what you're going to get out of that particular intervention, and you also know what the gap is in the field so that you can go articulate this message to others who might want to play in the same problem area as you would. So that's the way I would see that.
Thanks, Vikram. I will continue with you. Just push a bit on this. When we talk about GE Healthcare, I don't know if it's true with most, but what comes to my mind immediately is the portable ECG. But I was wanting to hear from you examples where you followed this approach, because the approach makes a lot of sense. But for people who may not be from a technology background, getting a flavor of what actually goes on. So when you, maybe you could take the example of portable ECG or something else, let's say I start with the system. How does it work? If you can give an example.
I'll give you a slightly different example. The portable ECG is my favorite, but there's something far more emotional. I'll give you that one. So we built a warmer for babies. And since Mr. Kumar spoke about reducing infant mortality, warmer is nothing but a device that basically thermoregulates the baby's temperature. So you essentially control the baby's body temperature. And ideally, you'll need a warmer for low birth weight babies. Anything less than, any baby less than 1.5 kilos. Less than 1 kilo needs to go into an incubator. So let's not talk about that. Let's talk about less than 1.5 kg babies. A vast majority of babies born in India are born that way, primarily because of the lack of nutrition to the mother, lack of sanitary conditions, so on and so forth. A lot of very, very basic needs not being met leads to that kind of a birth problem. Now, first assumption, we said, as I said, take cost out. So we took cost out. If I compare the product against which we designed the new one, we took almost 80% of the cost out. And that's a phenomenal feat. If you're an engineer, you got to be proud of that feat. Because taking 80% of the cost out of an existing device is never easy. And yet, retaining full functionality, retaining full capability, retaining complete clinical capability, without compromising any of that, we took 80% of the cost out. So what we said was, let's go sell this with a benefit to the customer, let's take 80% of the price out. We did that too. And we thought, the product is going to fly in the marketplace. One of the pilots we did was in a small primary healthcare center in Vellore, not too far from where our research center is in Bangalore. So, went and gave all this equipment for free. We gave them a warmer, we gave them a really specced out ECG system for fetal heart rate monitoring, so on and so forth. A bunch of things, including a phototherapy device, completely equipped sick and newborn care unit for babies. 6 months later, after the pilot, when I went back to the same site, as I told you, all these devices that we gave them were low-cost devices. And I went into the site. First thing that I saw, in fact, the administrator was so proud. He took me there, he said, sir, the warmer is always in use. I saw wet blankets inside the warmer. I said, what's happening? Why do you have wet blankets inside the warmer? It was raining outside. I said, sir, 5 days we've been seeing continuous rain. We can't dry our blankets. Mothers are feeling cold, so this is the best, cheapest, fastest, most efficient way to warm their blankets. That is the system at play. It's no longer the warmer. The warmer is just a very small sliver of intervention that was meant and designed for all the right reasons. But the system was, here's what happened, here's what broke down. So when the pilot was established at that facility, we gave training to all the people who were the technical staff, the nurses, the technicians, the ward boys, all of them. 3 months later, somebody found a job in Bangalore, so they migrated. And slowly over 6 months, the number of people who were actually trained came down to 0. And they had a brand new staff there. One, they weren't too adept at using the warmer. They did not know the clinical outcomes of using a warmer. The reason why they said, well, this warmer actually works well on a blanket as opposed to a baby, so why don't we use it for blankets instead? The choice was made at a level where it shouldn't have been made. But I can't blame that, right? I need to fix the system. If that's the system, I need to fix that first before I go put a technology at play. So today we make systems that are fault tolerant or decision tolerant in many cases. So today our warmers don't, if it senses anything other than a baby, the first thing it will do is give you a signal. It will give you a graceful exit. It will say, hey, you're not putting a baby in the warmer. Despite that, you want to put a blanket in, well, that's your call. So that's a very, very small example. That's how to implement the system.
Thanks a lot. I think that really makes it very, very real. Thank you. Vivek, I want to come to you. You come from a non-healthcare background, if I'm not wrong, in the sense that your first, maybe even couple of jobs were in a different sector. And we see this now more and more, that a lot of entrepreneurs come from a different sector and see an opportunity or think there is an opportunity in the healthcare sector. A lot of them are looking at devices, some of them may be looking at information technology, data. I personally think that your journey and your attempt was somewhat different in the sense that you decided to look at the B2B market. Maybe you're doing B2C, but the Amazon of, it seems B2B. And going back to the idea of the system being broken and hence the intervention, could you throw some lights on what were your initial insights? Where did you think the system was broken, which led to this innovation or intervention or idea? It'd be good.
Thanks, Professor Sarang. I think that will give me an opportunity to speak a little bit about my journey across different industries. So well, I started with FMCG industry, and I'll tell you my brush of technology with 3 industries separately. In fact, with FMCG, then moving to telecom consulting, and then moving to healthcare. You know, when I started my journey with FMCG, the biggest challenge in FMCG distribution was that consumption was never tracked. And we were working, I worked with one of the largest FMCG companies, heading brand and heading distribution initiatives, and the biggest challenge was that consumption was never being tracked, and people were actually facing a lot of challenges in terms of expiries, damages, and all those things. And that's where technology had to play a vital role. Now we see the change happening with Big Basket, with technologies which have actually brought consumers on the platform together to see how changes have evolved industry to a greater extent. Then think of telecom. Telecom, at one point in time, 99.5% recharges used to happen physical. You had recharges which had a lot of recharge options, shops, even panwalas and bidiwalas used to sell recharges. From there, the evolution happened with technologies like Paytm, where you have more than 99% now recharges happening online. That's the evolving technology which changed the industry, telecom industry, to a greater extent. When I joined healthcare, it was more so because of personal reasons. I had some happening in my family, and it made me think that I must contribute doing something in healthcare. Though I do not come directly from healthcare background, but I joined on the delivery care side and set up about 45 clinics all over India. And while doing that, I realized there is a huge challenge in terms of the complexity and accessing and getting the affordable options of medical consumables and medical supplies, especially when you are running your clinics into tier 2-3 cities. Just to give you some idea, I am sure many people would be aware here, but we actually live in a country which is 17.5% of global population. We have more than 640,000 villages. We have 3,100 urban centers or towns, what we call about. And we were choosing locations which were actually not getting covered with healthcare. In fact, only what we talk about, the best hospitals in the country, tertiary care hospitals, this only covers 28% of population in our country. 72% population even do not have a great access to tertiary care in our country. That's the challenge what we are facing today. So I was trying to set up kind of tertiary care into tier 2-3 cities, and the biggest challenge was, how do I make it much more affordable? I'm going to speak about the complexities and challenges more in the afternoon talk about cost relationship, but it was a spiraling cost. You know, there were intermediaries involved at all the segments. You did not have direct access to manufacturers. Manufacturers are limited with their approach to reach out to the places. They had to use multiple layer of intermediaries, and that was actually pushing cost higher, and it was also not feasible for a small unit to hold inventory for more than 5 to 6 months and maybe 3 months. In fact, there were times when we had to order inventory for more than 1 or 2 months and then hold the inventory, because the inventory carrying is also cost, and many people would be running private clinics here, and they would actually feel the pinch of having high working capital deployment in running these clinics. So I think that itself was a bigger challenge that made me rethink about how technology can change the landscape of actually accessing something which is critical for healthcare delivery, something as basic as medical procurement. In our country, we have pizza coming in 30 minutes and medical supplies does not even coming in 7 days. That's irony, right? So that's what actually I was thinking, and I was thinking to bridge this entire gap of medical consumables, medical supplies through an ecosystem. It is mix of technology. It's creating the best supply chain system. It's creating best inventory management solution. That's what we are evolving to do. We have created something unique into our platform today. I'm going to present it today in the afternoon. It's based on artificial intelligence and machine learning, and with a little bit of insight what we could gather from various places in the country. In fact, working at so many hospitals and centers, we could evolve with the technology which could give a great insight into managing procurement intelligently with minimum infusion of data. And that's where the change would happen with the small centers and clinics all over the country.
Thank you, Vivek. Mrinal, welcome. in the morning, Mr. Alok from Niti Aayog talked about fragmentation in the Indian healthcare system, both on provider side and also on the payer side. And I know that you are trying to do some interesting stuff that sits at the interface of the providers and payers. Could you start by talking about what you see as the main challenges when providers and payers interface with each other on the insurance thing, and where may technology help, but also in particular, could it help in that case to reduce cost, or could the value be somewhere else?
Thanks, Sarang. Firstly, sorry, I came a little bit late. But to answer your question, there is, as I've been studying the relationships and the way payouts happen between payers and providers, there is a massive lack of trust between the payer and the provider. And the fact that neither these parties, either directly or indirectly through some intermediary, are willing to trust each other, actually makes each of their problem worse. And let me just for a moment basically delve into the detail of how that happens. So let's say there's a hospital and the hospital ends up authorizing, the hospital ends up providing care, and the insurer at the end of that, at the time of discharge, basically says, all right, hospital, I'm going to pay you 2 lakh rupees. And here's in the IOU for 2 lakh rupees, I'm authorizing that at this time the patient can be discharged. Now, after that, the patient is discharged, what happens is, that's when begins the process of paperwork. A lot of paper is asked from the hospital, some of which the hospital supplies, the others the hospital doesn't supply, and in effect about 10 to 15% of the billed receivables that a hospital has is denied by the insurer. Despite the fact that the insurer said I'm good for 2 lakh rupees, on average about 20,000 rupees is denied by the insurer for all sorts of legitimate reasons, right? I mean, I think our audit went through this paperwork was not up to mark, etc., etc., etc. What the insurer is not realizing is, in this bureaucratic mumbo-jumbo, the impact that this has on the hospital. So in effect, by demonstrating this behavior, the payer is encouraging the hospital to over-invoice. Because now what the hospital is thinking is, well, look, I'm in any case going to get 10-15% of what I'm going to bill, so I might as well over-invoice. Now, the entire world basically, our entire country is telling how hospitals over-invoice. Well, guess what? This over-invoicing is something which to a large degree is basically they don't have an alternative. Hospitals are capital-intensive businesses. They have working capital flows. In this country, I think there are too few people getting to the root of why certain things happen the way that they do. Now the hospitals over-invoice. As a result of the hospitals over-invoicing, the insurers' basically policies are even more invasive. Like, tell me why you are invoicing the 20 rupees surgical gloves at 100 rupees. Right? And I think this interaction keeps getting worse. And over a period of time, I think this interaction continues to get worse. So at the heart of what's going on in the payer-provider system is this sort of payer, and now governments are about to get involved, payer who are unwilling and do not have the willingness to get into the details of why a certain problem is occurring, but trying to somehow ham-fist their way into saying, like, this is what has happened. And as governments get into this territory with, some of the universal healthcare happening, governments are worse when it comes to not trying to really understand the problem, but just trying to solve it by some, waving of the hand and saying, well, this is the rule. So I suspect this is only going to get worse. That's the heart of this, at least this commercial relationship. I think that technology has a huge hand to play in reducing this cost. So as I personally looked at the problem, what I realized is that the world spends, and I'll come to India in a moment, the world spends $8 trillion on healthcare, and the world spends $800 billion on settlement of health insurance claims. 10%. $800 billion is more than the GDP of Vietnam. It's more than the defense spending of all the countries in the world combined. And this is just wasteful spending. It's not money going to the doctor. It's not money going for pharmaceutical companies. It's just people, the bureaucracy of human interactions. And I think that's basically what this will solve. To begin with, technology will solve at least that, if not more. And that ratio of 10% is actually quite worse for India. It's basically in the range of 15-20% in India. I think to some extent, we are a country a little bit in denial. The problem exists, but we pretend that it doesn't. But I think if you really kind of get down to it, that's what the numbers say.
Very insightful, Mrinal. Thanks. Come back to Vikram. I think, if I'm not mistaken, a large proportion of our audience today comes from the healthcare background, from hospital providers. And the moment we start talking about technology at this level, it is likely that eyes glaze over, right? I mean, the training, the orientation is very different. And while all of us realize that we must catch up with technology, it is not that straightforward. You've interacted with provider organizations as well, and you talked about systems. Where should providers start? When they think of technology, where should they start? Should they think, I want to reduce cost? Should they think, oh, there's an excited person coming, jumping up and down with the technology, so let me help a little bit? Any thoughts on that?
Actually, my thoughts are fairly basic when it comes to that in the problems. Let's look at greenfield and let's look at, let's say, brownfield or established setups. So in the case of established setups, the issue is you've grown with time. You've grown with at a time when there was no technology available or limited technology available. Now you've reached a point in time where there's so much technology available that you really have to pick and choose whatever you're investing in. And therefore, it purely becomes a financial math of saying, okay, if I have to invest X, how much is X going to reimburse me in terms of the number of procedures I can do, throughput, productivity, quality? Because at the end of the day, the patient is capped on how much they can pay. There is an out-of-pocket payment, there is a certain value that they can spend, and there's no further reimbursements or subsidies that they're going to get from any other source. So therefore it becomes a very, very simple math in terms of saying, should I invest or should I just continue to live with what I have? So that's the established hospital story in general. I'm generalizing here. On the greenfield side, I've seen two sets of examples. One example that wants to be state-of-the-art but at the lowest cost curve possible. So they've already seen, and these are being set up by people who've been part of the system for the last, say, 30 years. They've gone through the evolution. They've seen how technology has or has not helped them. They've seen the bane of having, paper systems as opposed to paperless systems, so on and so forth. So they felt the pain. They want to avoid it, and therefore they want to spend the right amount of money, but on the right things that will help bring the cost curve down. That is a great place to start, but you can only do it if you're starting. It's very difficult to go down that path once you're already established. The second mentality among the greenfield is to say, I want to be state of the art, but I'm also going to be super focused on what I want to do. I'm not going to do everything under the sky that's available today. But if I'm going to do, let's say, cardiac care as a standalone shop, let me just do that. If I'm going to do an on-code dedicated center, let me just do that, but then let me put in place the processes and systems that are going to help my patients feel better at the end of the day, my doctors make better decisions, and me spend lesser money doing the whole thing. So I don't think there's one answer to your question, but I think there's an evolution of the thought process of how people are beginning to now look at technology much more proactively. I think the proactive piece of really looking at what technology works, at what cost, what's the benefit to the patient, what's the benefit to the doctor, and what's the benefit to the provider, I think that's becoming a lot more vocal these days when you go into these conversations. The other thing that I'm also seeing, again, among established players, is people are trying to bring, and this goes back to a small conversation we had this morning, a lot of people are also trying to bring technology inside their organization. They're trying to insource as much as technology because they want to do two things. One, it's a cheap and easy way of testing what works and what doesn't, without having to invest in it. So you bring technology in-house, you let them do a pilot in-house, you see the benefits and then decide to invest in it. If it doesn't scale, it's good feedback to the technology provider. If it scales, it's great for the healthcare provider because you then invest in it and see how the benefits flow back into your own financial books and to the patient. The last thing that I would say is, as far as adoption of technology goes, technology is just an enabler, right? At the end of the day, doctors need to practice what they're taught to practice, and provider ecosystems are fundamentally running a business unit. A hospital is no different from a manufacturing industry. Instead of manufacturing parts, you're saving lives. That's the simplest way of looking at it. Now, there are multiple redundancies that you have to build because you're dealing with somebody's life as opposed to getting a part wrong. But I think therein comes, in my view, if you can identify the biggest leakages in your system and put in place the right technologies that can fix your leakages, that would possibly be the easiest way of spending something and seeing the returns on an immediate basis, as opposed to looking at what's state of the art, what's the next best, bright and shining object to go buy. I think looking and fixing at your leakages would probably add more value in today's times.
So if I understand correctly, the first step is to analyze your processes, the way you are delivering care, your systems, find out wasteful steps, and then ask whether the technology can help in some places, maybe not all, but some. Yeah, that's very helpful. Yes, please, Vivek, go ahead.
In the last few years, in fact, my interaction with various hospitals and doctors per se, what we have realized and what essentially has been happening and why there is a bit of challenge in adoption of technology in healthcare, because technology behavior is not chasing people behavior. What is happening is people behavior is chasing technology behavior. There is artificial intelligence, everybody is running behind artificial intelligence. There is something like machine learning, everybody is running behind machine learning. But what is actual impact of it? Any technology can only be a great enabler if it actually makes your life simpler, gives you some advantage on your cost, gives you some benefits on your revenue, changes your processes dramatically. I think these are some things which technology can address meaningfully. Why all technologies we see today are what we see as Airbnb, what we see as Flipkart or Amazon or Uber or Ola, because it has changed behavior. It's giving you an edge, or it's maybe saving you a lot of time, or it's giving a lot of convenience to you. That is why these technologies are getting adopted. I think one big technology which could have been a great enabler was something like online doctor appointment, that what Practo used to do, because that was a great enabler at one point in time, but I don't know why it got lost the track and it's just everywhere, because that was the great opportunity for everyone. That was one large convenience which healthcare was always looking at.
And that's a good point. And I have myself done some research on telemedicine, and we can chat later, but there are reasons, because again, you've not got to think about the patient first, and the value that an online consultation provides, there may be more promise there than reality. I'll come to you, Mrinal, next. You talked about a sort of a very interesting interplay between provider, payer, and where value can be created through technology. Technology used to generate trust in some sense. Again, for our audience, where can a clinical person or a medical person help in innovations like these? One question. And second is, have you thought about this value created? Would someone be interested in paying for this value, and have you had interactions? Because that's the other thing, that if you have a consumer of technology who is very unaware of technology, there is a third, sort of second trust issue between the technologist and the provider. Once you say AI, ML, I just look on the other side. So what role can actively be played by clinical people, and will that lead to better adoption?
Yeah, actually both are very, very good questions, and especially very relevant in India. I think I think the role that a medical person plays is that of a subject matter expert, without which you cannot really innovate. So, just as an example, if you go to any of the startups who are trying to, or any technology company in the United States who are trying to do AI in healthcare, which we've all been referring to, all of them have a position called CMO, which is not Chief Marketing Officer, it's Chief Medical Officer, right? So without that person, you actually cannot, you can't really do this. So I think the way I think about, the way I've been seeing evolution of not just healthcare firms, but across industries, I think you have the old guard, right? Who basically knows what that industry is about, but their thinking, and the old guard thinking is, and by the way, I mean no disrespect to strategy professionals, because I myself was one, right? But strategy is about taking what is there in the world and trying to make sense of it. And disruption is basically about taking all of that, putting it in a basket and basically completely reinventing. And those two worlds don't go together very well, but they can be made to work with each other. I was Chief Operating Officer of MobiKwik before I did this, and I saw this in financial services. Absolutely no banker in the world understands what the fintechs are trying to do. And it's a similar conversation here in the context of hospitals. Let's not even pretend, as a hospital practitioner or a person who comes from, or who's been a practitioner in this industry for long, let's not even pretend we can even imagine what is possible. So we first need to understand, if I am a practitioner, I first need to accept and have the humility to understand that I do not know anything about disruption, and I likely cannot lead it. I will in fact not lead it. Then I look for somebody who's likely not a healthcare practitioner. They may be somebody from consumer tech. I think an example of Practo was given, that the CEO of Practo, Shashank, was not a healthcare professional. The guy who started Uber was not a transportation specialist. These were just people who came from technology backgrounds, and we speak about technology as an enabler, and I think sometimes we think, oh, it's just an enabler. It's like saying diagnostics are an enabler for healthcare. Can you imagine healthcare without diagnostics? And I think that's the flavor of the world. We need people who have the ability to think of the world disruptively, and healthcare professionals need to bring them in, and they will completely reimagine and rechange the provider setup. And in that process, a practitioner can help, just like the CMO. But I think that's how disruptive change will happen. Whether we want to be one of those people who are doing a disruptive change or not is up to us. And now very quickly, the second question. I think we, in India, and it's different in the West, we don't really understand the value that technology can bring. We say we kind of do, but we don't. And that is the reason we're not willing to pay for it. So anywhere in India, if you try to sell technology and technology, people will not pay for it. And therefore, and I could be wrong, and time will tell, but I'll basically use technology, but I will basically not tell a person that I'm using technology, but I will take money from him in some other guise. So I'm not going to charge for the tech, I'm going to charge for some type of business service, and in charging that person for the business service, the basic work, all of the operations is actually being done by the tech. We in India, we have a handicap. The moment I throw people at the problem, the person in front of me is suddenly willing to pay. The moment I use technology, he's like, tell me how many software engineers do you have and what is their salary, and I'm going to give you 10% more than that. And instead, we should be, the better way to look at it is, let's also understand what part of my problem and pain is getting solved. We in India are not configured to think like that. The West is configured to think like that. And therefore they pay, monthly software license fees. But we must understand what we are doing to ourselves in this process. The fact that we are not choosing to embrace, license fees for software or whatever that the technologist is going to ask, we are enabling our own disruption, because that guy is going to figure some business model, and then in the business model, he's going to figure a way out to make more money from me than I would have given to him if I had simply paid him a license fee. So, I think that's my answer to the pricing problem. Of course, there will be enough people, enough technologists who will try to solve it the good old way by doing license fee and fail, and I see that. But there will be people who will come along who will take the shirts and pants of this system, because our country is not willing to pay software license fee. And an example of that, a friend of mine runs Yashoda hospitals, and he was telling me that, I am stunned that I get my IT department to tell me, to bring me codes of hospital information service providers, and the guy tells me, and he's like, the most expensive one is 3 crores. And he said, I fell off my chair, like 3 crores, that's all? Why are we willing to pay so little for hospital information, something that is as critical as hospital information system? Like, the analogy of it, the nervous system of that hospital is this thing. The problem with this is we'll get what we pay for.
This is a good point, related to what we call as input-based and output-based contract. For long we have been trained to think, let me calculate all the inputs that go into a particular process, and whatever the cost of that is, I will give a respectable and reasonable margin on top of that. Because this notion of I want no one to profiteer at my expense, but we need to think we are also gaining something, and that value may be intangible. Cost may be very tangible. That's a great point. I'll pause here. We will take questions from audience, and then if one question that I want to ask no one asked, I will ask that in the end. But let's go to the audience now. Can you move the mic? Okay, we go maybe here first and then there.
Dr. Singhal, Vivek raised a very important point that the technology somehow does not seem to impact the behavior of the healthcare seekers. That's a very important point. Perhaps if we delve into it a little more, we will realize that what happens. There are, to my mind, a couple of reasons. One, that maybe our technology is not really geared for the need of the patient or the healthcare seeker. That is one. Second, any health problem, especially the NCDs, you look at NCDs, they require lifestyle modification. And there is a lot of resistance in modern day life to embracing lifestyle modification. Simple lifestyle modification like doing 45 minutes of exercise, cutting out on calories, having a regulated lifestyle. There's a lot of resistance on that front. And perhaps these may be some of the reasons why our technology does not impact patient behavior so much. And we need to deliberate on this at some other point and make some strategies. Unless we impact the behavior of the healthcare seeker and make him an equal partner, we will not be doing full justice.
Great. Just as a moderator now, I can come in and say, there wasn't a question there, but it was a great comment. But could you respond? So let me pose a question. Have you thought of technologies or seen technologies that are changing, let's say specifically health-related behavior of patients and create value?
So, I think it's already elaborated well, but any technology adoption or any adoption has to challenge the status quo. That's the biggest bottleneck. When you challenge the status quo, there are multiple frictions or references, as we know very rightly about Newton's third law, right? That how do you challenge the status quo? How do you make changes happening in the system? I think the biggest challenge we have today is every technology piece in health tech is isolated, and that only solves a section of the problem, which itself is like not that great in terms of size or maybe the context we are looking at. Like what Mr. Alok Kumar has shown sometime, that there are multiple technology addressing multiple sections, but there is nothing like a complete end-to-end technology addressing the problem. I think that's That's essentially the technology curve. You can't have every solution at the beginning. You have to evolve with the solution. I think that's where every part and kind of effort will try to bring in the change which we are looking at. Everyone can't look at a complete 100% solution because it's all related to time, resource, effort, cost we put into create that change. I think that's where it's more important.
Really commendable when technological advances, but with that reduction cost, there must be some responsibility of the technological for low affordable equipments and everything. Because I will tell you a story in my hometown Pune, where a gynecologist was being sued because a one-day-old baby got burned because of some glitch in that low-cost warmer the baby was being put in. Now, for all such things, who should be held responsible? Who does the media make a scapegoat? The doctor or the engineer? Who should take the responsibility?
Without getting into the details of that specific case, I think the answer is fairly simple. There are two things the entire healthcare ecosystem can't compromise on. One is patient safety, second one is patient ethics. These are the only two non-compromising attributes of a healthcare ecosystem. Now, of that, you can then allocate responsibility across the ecosystem. So if I am the technology provider providing the warmer, it is my job to make sure that the warmer meets all standards of certification, regulatory authorities, quality, reliability, so on and so forth. I stand liable for any failure of that particular component that I've supplied. Now, if the gynecological practice is what went wrong and the baby died, then the gynecologist has to be held liable for their service in terms of what they have delivered. Or if the insurance is going wrong in terms of non-payment and because of that there was an outcome, then that's another responsibility that needs to be allocated. So, in my opinion, the end of the life, the end of the entire journey, patient life is sacrosanct. That's the only thing that everybody here is trying to work for. So patient ethics and patient safety has to be guaranteed through all possible measures and metrics. Now, Mr. Kumar spoke this morning about the need for regulatory agencies to come in to direct the use of health IT infrastructure, so on and so forth, or NABH certification, hospital quality certification. There is a bunch of regulatory things that we need to go through. None of them are in place in the country today. So everybody is taking their own call in terms of what is the right regulatory standard to certify themselves against. It's almost a self-certification mechanism. So as far as I can answer for GE, as far as a company like GE or almost any other MNC at play here in the country, will follow global norms. So you will take the highest norm available, which is like an FDA standard, and apply it across your product line. Whether it is sold in India or Egypt or USA, it doesn't matter. The same warmer that I spoke about in my example, which we gave in Vellore, also goes into labor and delivery wards in Brigham Women's Young in Massachusetts. Exactly the same warm. So I think it's about really getting into your mind that healthcare, patient safety, patient ethics are completely non-compromisable. That's where your integrity lies. Beyond that, I think it's up to the regulations to actually play a role. So that would be my answer to that specific question.
Okay, closer to you first. Then behind and then front.
Well, Ishwana, it could be the perspective of mine, then I'll put forward the question. See, the four panel members, okay, I get to say researcher, a benchmark, a techno entrepreneur, and from a consumer background or services. After 18 years of experience, I have seen that health, because they do work in silos. They don't work, I mean, that's my personal perspective. The doctors and the techies, they work in silos, and that's a majority of the reason the best products are not coming or it's not able to transform. Now, a question to you is that how, like, from a G perspective, I understand, but from the new technologies which are coming up, how do you feel that they enhance doctors and techies in hand to developing a new product to launch in market? That's what my question is. How do you see the trend right now? Is there any change or it remains same?
So I think that there were many sub-questions in your question, but I think that whenever anyone is out to solve a business problem, and therefore I'm talking about private sector or a startup. You almost can never solve for everything, and therefore you pick the segment you want to serve. And I almost want to say something provocative, like it's okay to serve somebody in silos. Some of the greatest companies in healthcare in India, I would term Thyrocare a healthcare business, and it's super siloed, right? I think in terms of what it delivers, but what silo also means is that you're razor sharp focused on what you're doing, and you're doing it at scale. So I think that it is almost the facet of good businesses that they will define the problem that they're trying to solve very, very narrowly and sharply. And to that extent, they will therefore be siloed. If one were to call Thyrocare siloed, of course it's siloed. Because it doesn't solve for a lot of things in healthcare, it solves for a very specific problem. So, and what I see of how technology will impact this, good technology and good technology platforms will actually identify the problem that they're trying to solve very, very sharply and narrowly and in a focused way. And in it, the more clearer and sharper and in a more focused manner that they can define the problem, the higher will be their chances of success and the higher the impact on all of us. And to give you an example, we all know how Uber changed transportation. It's something that entire governments could not do. With their budgets, with their massive budgets, and their ability to tax the hell out of people and their ability to put policies, any government worth its name in the world could not do what Uber did. And Uber, when it started out, it had a very specific metric. I want to get a taxi to a user within 2 minutes, and that was their benchmark, 2 minutes. That's how sharply they define the problem. Are they siloed? Of course they are. They're only providing taxis, etc., etc., etc. It's not public transport, carbon footprint. God knows what will happen to the carbon footprints, etc. But I think that the technologies which will actually fundamentally change our lives and change the world will pick the problem that as specific as Uber did.
Yeah, so Abhishek, I get your question. In the interest of time, I suggest we move on, but I'll paraphrase for Mrinal. I think his point was not silo as one single service, but silo of a tech person and a clinical person. And should they come together, breaking those silos to create something which is...
What's happening in yours?
Yeah. So, but if we can take it during the break, it will be great. Yeah. I think there are 2 questions, so I would just like to wrap up the session with those 2 questions. So, the person there.
So I'm Dr. Ashish Sahani. I'm coming from IIT Roper Center for Biomedical Engineering, Medical Devices Lab, and I wanted to kind of add on to that what my friend here asked, because I have been active in this field, and one thing which I find different in terms of medical device research in India is that our clinical infrastructure, clinical systems of education and healthcare and engineering, institutes of eminence, they are completely siloed in 2 different, complete domains. They don't know about their programs yet. So while I have worked at National General Hospital and after that at University of Michigan, and I was working inside the hospital developing software. So that's what I find, if we really want to push for bringing out any new impactful innovation here, we have to, government basically I would like to, if there are government representatives, so that is where I think, how do we bring about more and more programs which make clinicians and healthcare researchers from engineering side to work together, maybe build, for example, IIT Kharagpur has recently built, is working on building a medical hospital inside IIT Kharagpur. That's the first, I think. So,
I think I can just put a light on your question. So there are multiple initiatives being taken by government bodies differently. In fact, if you heard the name of Kalam Institute of Health Technology, which which is far.
So they are a facilitator organization. They like if there are industries which want to develop something, they have a lot of facilities that they're building, which they can use. But in terms of research professionals, for example, we have, and then there is a gap between private medical hospitals and government medical hospitals. Private medical hospital doctors are generally not interested in research. In government medical hospitals only, they have an incentive towards doing some research because they have to show some publication. While in IITs, we have full-time PhDs. Most doctors don't do PhDs here. In IITs, we have full-time PhDs and they do 5 years of research. So there's what happened, and most of our hospitals are overburdened with patients and they don't have time for actually doing much of the research. So if we can bring in that, joint program or some kind of arrangement where they can give certain amount of time, and wherever there is a lot of manpower or facilities available for research, they are researching.
So I'll give you two quick notes to your question. See, as a country in India, we are still not matured as medical devices innovator or innovation country. If you actually see innovation happening outside India, most of the companies I interact with, in fact we work with more than 500 companies from outside India, most of the innovations actually happen in the framework you are talking, where you have doctors, they come with the problems, innovators take up the problems, they design the equipment in the best feasible manner or the device in the best feasible manner to tackle the problem.
Ultimately, doctors are one of the major consumers of the technology.
That's right.
So it's not probably many times the patient, it's the doctor who is actually the consumer, and he has to probably look at what is his need. And many times doctors themselves, because they are trained to be absolutely accurate, while engineers are not trained to be correct all the time. So they generally are averse, risk averse. So they don't want to experiment too much. So that's where I forget Mrinal. Yeah, he gave these two, that disruptors versus the strategy guys, and that's that point which very interesting.
Thank you for your comment and question. Last question here, if you can get the mic.
Hi, I'm Dr. Neelamon. I'm a pediatric hepatologist and a director at Medika Medicity. It was really interesting to listen to all the experts, but my view is that the future is going to lie in, we doctors are mostly trying to treat pathology. We're not focusing on the biochemistry and physiology. If the technology makes us understand the biochemistry and physiology at every moment, we're going to bring about real breakthrough innovations. And that could be, as he mentioned, doctor-centric innovations. We are all focusing on healthcare delivery and doctor-centric. It is time, Dr. Sarang has always been teaching, that you need to identify who's your main thing. So my main focus needs to be the consumer, the patient. And I guess it's time that we need to focus our innovations there, and I would love to talk about it during the break. But your thoughts, did you ever think of changing the paradigm and looking at the consumer and what innovations you would love to bring about there if we are able to understand that thing? Thank you.
A quick shot at that question. I think the world is evolving that way. And I'm not sure if you've read about the Human Longevity Program. That's of course running out of the valley. Those programs can only run out of the valley. But I think it's an interesting program because you're thinking about how do you now live for eternity. And that goes back to what you said, which is going back to the basic building blocks of the human genome. How do you make sure that you start editing it the day you're born or you're born right? Very, very ethical questions to ask, very, very difficult questions to answer. But I think give it maybe 25, 30 years at least, that's the time horizons that I'm seeing in published journals, that we will get to a point in time where you can actually edit the way you want to live. Literally, it's like a Control-C, Control-V, whatnot. So I think until that point, there's two things that we can still work on. One, I'm a big believer in prevention, a massive believer in prevention. And unfortunately for prevention, I think large part of it has to do with human behavior modification. So if there's anything that we can actually do, and some of our experiments have associated the usage of technology that can actually drive patient behavior modification. Let's take tobacco cessation for example. Nothing that you do, whether you increase the size of the photograph on the cigarette pack to 85% or 90% or 99%, I don't think it's going to work. Because people want to smoke. It's as simple as that. So given that level of paradigm, technologies that can actually infuse chemical change in your brain to, actually send the right messages and fire the right neurons that will tell you, okay, here's a cigarette pack and you're not supposed to touch it. I think that kind of interventions will be the interventions of the future. But again, these are very, very difficult questions to answer because you are invading into my privacy. Because you are invading into the way I want to live. And I think that's a tough one. Coming back to more doable things like CRISPR. There are new technologies that are in the market that can actually help you understand the histopathology, the biochemistry, the actual morphology, and the topology of the disease for you to be able to go and edit specific things. So if you want to treat it right, you can actually treat it right the first time and get it right. Rather than having to go through an experimental way of, let's try this, if it doesn't work, it's got an 80% chance of success, let's now go to drug B. Rather than do that, things like this can actually help you get there, but that again is a research mode. So the long and short of it, we will get there. I think you're going to have a new set of problems to deal with once you get there. May not be anything to do with the actual treatment itself, but it would be more to do with the ethical ways of delivering it. But that would be my view.
Vikram, thanks for that response. I think it's hard to top that moonshot, so I'll stop at that. And probably summarize very quickly in a minute or two. I think technology, what we heard just now, technology can be very simple. Vikram started with the low cost, low tech baby warmer, very important. And Vikram ended with high tech, really high end technologies. So technology is all over. And for healthcare, I think the question is, as professionals in the sector, as clinical people, as medical people, do we want to get disrupted? Or do we want to be part of that disruption and probably shape the disruption? To what end is the question? Cost, we started discussing, but we did impinge upon quality and access, which are the other two things that we need to keep in mind. I want to close this by connecting to what Mr. Alok was saying earlier. All of this discussion, please realize, is happening in the context of Indian healthcare system, which is highly fragmented on both provider and payer side, as well as patient pathways. So as we think about being part of the disruption or try to avoid disruption, we have to, at the end of the day, think, are we adding value to that system? Are we improving that system? So I'll stop at that thought and then break for, we have the next session.
Thank you, Professor Sarang.
Yes.
So thank you, panelists, for this wonderful brainstorming session.